Thank you. Amazing and promising future oral treatments. My question is, because I come from Egypt and I always think economics, do you think that some of those are going to be a bit cheaper than the injectable biologics? We don't have them. For example, we don't have TYK2 inhibitors right now in Egypt, so I have no idea. The JAKs are pretty expensive, but do you think, for example, the newer oral anti-IL-23s, for example, are going to be a bit cheaper than the biologics, and maybe with more thinking about my patients, they will be more accessible because this is the way we think about it?
Sure, so happy to comment on that. I mean, I think there are so many players within the psoriasis market with 13 biologics or whatever we've got now and several oral molecules that certainly in many countries price is being driven down. I know that's not the case everywhere, but of course biosimilars, we're very close in some parts of the world having ustekinumab as a biosimilar as well.
Adalimumab as well, yeah.
Yeah, and you know, the cost is becoming really very, very low with those biosimilars, almost less than drugs like cyclosporine, for example. So I suspect they'll still come at a premium because of the massive amount of investment that it takes to develop a drug. But I think because of the competitive nature, they're unlikely to be at the same premium as the biologics, the first launching biologics. But I therefore think for a period of time it might be prohibitive for some areas of the world, sadly. Yeah. But I guess the hope is that as we get more and more biosimilars and other drugs come off patent, the range of therapies we have available worldwide will become wider. But sadly, I'm not convinced it'll be these new orals that hit that space first.
My other question to Ron, please, is about do you have any concerns about DVT or any problems with the TYK2 that the other JAK inhibitors? Or because one of the nice things you've said that the side effects are really boring, and this is one thing that is worrying us about the regular JAKs that are on the market right now versus the other biologics. You know, you have to monitor the patients, if he's older, if he's a smoker, if he has history of DVT. What about the TYK2? Because most of our psoriasis patients as well as they have so many comorbidities, so we have to be careful when treating them.
So thank you. So I didn't go over the adverse events. I did more of the blood monitoring. I'm not concerned with VTE in the TYK2 inhibitors. There still are side effects. Patients do get headache. There's still the upper respiratory tract infection. There's sometimes acneiform eruptions that can occur as well. And some people would complain of reactivation of herpes simplex, but we don't immunize the patients against shingles for TYK2 inhibitors. It's not necessary. Therefore, delaying treatment. So every drug has potential adverse events, but with these molecules very tolerable. And the concern with thrombosis with TYK2 inhibitors is almost non-existent. So it really deserves its own category.
Thank you. Thank you.
Come to microphone one, but I note it's Professor Reynolds from Newcastle, and as he asks particularly hard questions to me, I'm going to nominate Ron to answer it.
So this is a question for Richard.
I don't know.
A really great session. So it is quite a tricky question, but it's an important one to consider conceptually. So you illustrated quite well how the small molecules may have difficulty inhibiting IL-17A compared to antibodies. And I wondered, even with the AI, whether that is going to be limiting, because it's clearly at the moment less effective, or is there an in vitro assay that you can do before you get to doing the clinical trials that's going to tell you what the deal is? So
in answer to your first question, I think the mean PASI change actually for the 800 milligram dose, starting because of where it started from, that mean PASI change is not a huge magnitude difference to what Cosentyx showed in some of its very, very early studies. But I do agree that this might be the start of a series of molecules, and that might not be the one that makes it all the way. And I know that there are many companies that are working to get if you like, better, more robust binding. In response to your second question, I'm not fully aware of the assays that are being used, if I'm being honest. But I think actually the 800 twice a day is in phase 2. And I think we'll get a much clearer readout when we get 40, 50 patients on these therapies of where it's maybe landing. But as I said, when you look back in Cosentyx very, very early on, it's not a million miles off.
Okay, great. That's encouraging. Thanks.
Hervé?
Yeah, thank you. Great talks, both of you. I mean, that might be a question for both targets. I mean, the IL-23 axis with small molecules, and also, but mainly for the TYK2, because this is already marketed, right? So you mentioned this boring regarding the safety profile. The question is in the pre-initiation kind of checking that you are doing, and are you treating any latent TB? And the reason I'm asking is that I assume the answer is yes, because there are some loss of functions mutants of TYK2 which accounts for monogenic forms of TB, and it's 2% of the TB disease worldwide, so it's not neglectable. So should we really pay attention to that? I personally believe so. It is not any big drama. It's just that, you know, because the oral you might sort of de-dramatize, and because I agree with you that the safety looks really great, but you know, just to pay attention to this kind of target-related issue.
Yeah, I think that any patient that I'm starting on an advanced systemic therapy or biologic or TYK2 inhibitor, for example, should be screened for latent TB and treated. If it was feasible, we could treat all patients with latent TB. If if there's a change that's required in the treatment, so for example, we start them with deucravacitinib because that's the only one that's on the market right now, and after 6 months to 8 months, the patient's not satisfied, or they're having an adverse event, or they wish to switch. I know that I've already done my due diligence in screening for the latent TB and getting them treatment as well. So I think that's another advantage. But I do agree they still should be treated. We know that there's no reactivations with anti-IL-17s as well, but we still would treat that patient in case we ever need to switch, but just in general medical care.
We don't see the 17 blockers. Well, we treat anyway, but I'm not aware of any reactivation of the 17 blockers. There was a contingent of patients in the studies who were not treated prophylactically.
Yes.
Yeah, right. So
they don't
there
have
is
to be.
Yeah, I mean,
I actually think it's sort of
a bit specific. Yeah.
important to think of the numbers needed to harm with the treatment. To be honest, in terms of not necessarily for TYK2, I think TYK2 is slightly different because it's broader. But I think for 1 or 2 patients with 17s or 23s, you might really want to consider, is that absolutely necessary based on their liver and other risk factors for being exposed to those therapies? And you know, the data is backing that up, albeit there's only the risankizumab program that studied it formally with 31 patients who didn't have prophylaxis.
If I make one comment, TYK2 translates or leads the transduction of interleukin 12 besides interleukin 23. Exactly. So it's more like ustekinumab. So I definitely would check for latent tuberculosis and treat those patients. It's not like IL-17 or IL-23 pure inhibition, in my view.
I'm Dr. Hanan Nada, Professor of Dermatology, Cairo University. I'd like to ask about one important point, the specificity and selectivity of the TYK2. This is the one I'm too much concerned about, or any JAK at all. Any JAK or TYK harmonize or control several types of cytokines. So when we make a JAK inhibition or TYK2 inhibition, we could affect other cytokines, or it just affect only the pathologic increased cytokines, while the normally circulating levels of other cytokines normally found in the body are not affected. Second part, I wanted to ask, we can combine biologic together with anti-JAKs or something like apremilast, or And the third part, can we take the level of platelet as something predictor for the persons who can develop thromboembolic disorders later on or not?
Okay. What was the fourth question?
No, the only.
The first
Oh, it was only three. Okay.
Only three.
I got lost after the first one. Platelets, I'm not concerned at all, and I don't think it's a measure of anything significant clinically.
Yeah.
Combination, yes. I think that I used to combine apremilast with a lot of biologics, but cost became prohibitive. And I think in terms of safety, I don't have any studies to support it, but anecdotally, I have combined deucravacitinib with a biologic as someone that had palmoplantar psoriasis that just did not respond enough with the injectable biologics.
Anti-JAKs and anti-TEC can be combined. We have experience about as regard the apremilast and tofacitinib, but as regard the newly emerging ones, can be combined.
I don't have evidence to show that it can, but in terms of safety, they likely can be combined, but it becomes truly cost prohibitive. With respect to the first question, the specificity, you need a high dose of oral TYK2 inhibitor to affect any JAK inhibition. Like that, it's a dosing that you would not give in clinic at all.
Just to add to that, I think Ron's right. I mean, experience of combining these things is so limited because of cost. But actually, in rheumatology, I'm aware of colleagues who have been combining certain biologics with certain JAKs. And for example, the data for upadacitinib is pretty strong for psoriatic arthritis, and yet I don't think alone for your worst patients with psoriasis it would necessarily hold the disease. So sometimes the thought of combining a high efficacy 17/23 that have a fairly clean profile with a JAK for PSA, that's certainly something I'm contemplating in clinic, although accessing that is not altogether easy.
I tend to prefer switching to something more powerful rather than combining, but that's an opinion.
This is my idea. Because in the GIT, sometimes they combine three biologics and anti-JAK together. That's why I'm asking in our experience in derma. Doctor, my question as regards safety and specificity. We have a normally circulating cytokines and the pathogenic cytokines in the disease, The JAK control a lot of cytokines. The dose I am giving for psoriasis, for example, will not affect the normally circulating cytokines that works through that JAKs? This is my question.
In terms of JAK, I'm not sure, but in terms of TYK2, I understand what you mean. It's unlikely that it affects a lot of the circulating other cytokines because we don't see the adverse events that you would see based on that.
This is the strange thing for me.
So, for example, you're not seeing candidiasis.
Might be it works on the pathologic only. Might be in such a dosage.
As a follow-up, I would add that the TYK2 drives intracellular signaling of interleukin 12 and 23, interleukin 6, interferon alpha and beta, and perhaps interleukin 13 too. But so that's the only thing that the only cytokines that should be affected. But regarding that, it's a bit of a concern that by blocking interferon alpha, we are not seeing a signal regarding herpes zoster or herpes simplex.
This is the one we don't. This means it works through the pathologic. Might be the dose is the one to control that. Might be. Thank you, doctor.
Yeah. Thank you.
Just one nerd question for you.
I've got a question for Ron, actually.
It's
do the TYK2s work for hair loss, Ron? You can ignore that question, I'm joking.
No. Sorry, Lewis, and sorry, Rich.
No problem. No, it's blocking. I can understand that by blocking the receptor, the levels of the cytokine increase because there's no internalization and metabolism and the like. How does it come that by blocking interleukin 17A, the levels also increase? I'm talking about DICE 806.
Yeah. So my understanding is that it has to be combined with its receptor to allow endocytosis of the 17 and clear it from the serum. So then you get an elevation if you've got target engagement. And I think this was from papers in about 2015, but I would have to go back and look in detail to give you a further explanation. But that's because it didn't intuitively make sense to me as to why that was going to be a good biomarker of engagement, but that's how I understand it.
It's different from the blockade by antibodies, you know?
Yes. No. You do with antibodies, you would also see the same. Yeah.
Okay, thank you. And the other question is that seeing the results, is this drug or this company worth 2.4 billion?
No comment.
I don't like discussing finances.
Thank you for the lectures. There are differences in the paradoxical psoriasis or paradoxical reactions between the biologics and the new oral medications.
Happy to give one comment. I mean, there's a number of different, I think, what we call paradoxical reactions. And in Manchester, we've had a PhD student, Ali Jinabi, who's been particularly interested in patients who seem to develop an eczema phenotype on exposure to individual cytokine blockade for psoriasis. And Ali's done some very eloquent publications in JAMA Dermatology, the JID, and the JACI journal that have, I mean, they make a lot of sense, but he's gone and studied proteome, he's studied genetic and produced a genetic risk score. And it's very, very clear that patients who at least go on a biologic, they probably have they do have a family history risk for psoriasis, but often they have a family history risk of atopy. And it's probably that overall the genetic burden is a bit greater for one disease. When you block that pathway in a narrow fashion, the other disease then expresses itself. Whereas obviously if, the JAKs would be ideal because they may cover both components of it. I think the story is slightly different for other paradoxical reactions, but I thought, would share that about the eczema element of it.
And for psoriasis, a lot of the paradoxical psoriasis that occurs, let's say in a IBD patient, it may be interferon induced, and therefore deucravacitinib may be beneficial in that by blocking interferon without causing adverse events of severe blockade. But it may be enough to help the paradoxical psoriasis in that regard. But we don't have testing to know why that person had paradoxical psoriasis. That would be the ideal, but I don't think it's going to happen in any of our lifetimes.
It might work for perniosis if blocks interferon alpha.
Yeah, always thinking, Lewis.
Beyond. Okay. Some other questions? If not, it's my pleasure to adjourn this session. We have enjoyed a wonderful trip around pathogenesis of disease, evolution, and also disease relapse and progression, and finally novelties in therapeutics. Thank you, everyone, all my co-chairs, all the attendees, and the International Psoriasis Council for having hosted this symposium. Enjoy your stay and your congress.